Hello, my name is Sai Rachakonda, and I'm a rising senior here at Duke, majoring in Program 2, which is a self-designed major in personalized healthcare innovation and policy. This summer, I was a Duke Margolis summer experience health policy intern here in Durham under the mentorship of Dr. Anna Hung. I chose to participate in this experience to have a more intensive research time to focus on a specific topic in health policy that I'm passionate about. My work with the Margolis Summer Experience program focused on conducting a systematic literature review of existing work on the efficacy of patient insurance decision aids and creating recommendations for future directions. So, to begin, many patients find selecting health insurance plans an arduous and really confusing process, and this is due to many factors. The first is the complexity of our health system here in the United States. There's so many different moving parts, and a lot of the burden is put on patients to understand. Many patients have potentially competing insurance plan options that can lead to more confusion. And a lot of patients have a dearth of non biased decision support to help guide them through the insurance selection process. Patient insurance decision aids, or PTDAs, can equip patients with better tools to assist their insurance selection process. And they tailor relevant information and offer further support in helping patients understand costs and how exactly to select the best plan for them. PTDAs were also theorized before and envisioned to help patients select lower cost plans or higher value plans, which is super important in the current insurance landscape. And many have also posited that PTDAs can help patients decrease risks of insurance related financial toxicity. Now, financial toxicity refers to the adverse financial impact of medical expenses and healthcare costs on patients' lives. It can cause stress, anxiety, and even lead to non adherence to treatment plans due to the inability to afford care. Now, some PTDAs are thought to help mitigate this and other related factors by including information on understanding insurance options, including coverage details, cost estimators, and info on provider networks. And all of this is tailored to create personalized recommendations, as we see later on in this presentation. In this specific study, we were looking at the efficacy of PTDAs broadly and examining various design features that can increase their efficacy. Now, this study had two big parts. The first and most important to this poster presentation is the systematic literature review. Our main goal was to summarize randomized controlled trials, or RCTs, on insurance-related PTDAs. Now, we applied PRISMA methods for review documentation purposes. And for those of you who don't know, PRISMA stands for Preferred Reporting Items for Systematic Literature Reviews and Meta-Analyses. It is an evidence-based minimum set of items that you have to report for reviews and meta-analyses, and it consists of a 27-item checklist and a phase flow diagram, which you can see here in Figure 1. We screened 168 studies, and I found these through relevant search items, through Google Scholar and PubMed. And we put them into Covidence software. And this is just a place for all of the studies to be organized and adhere to PRISMA guidelines. And through a 3-phase process, we whittled down the 168 studies, removed duplicates, and then we did a first screening based on titles and abstracts. From there, we removed those that are not relevant. We did a second screening that was a full text, and we wanted to make sure that it was adhering to our inclusion-exclusion criteria, which I can talk about a little bit later. And then we found 12 studies that were RCTs and that were included. Now, we generally included items that didn't really talk about insurance decision aids specifically, because decision aids is a broad field and insurance decision aids is the focus of this study. We excluded studies that weren't really randomized control trials and instead were like observational studies. And we excluded a lot of work where the decision aid itself was not the study focus. So these included studies and that talked about more so about like having choice sets and how that can impact insurance decision choice. However, we included studies which had PTDAs as like a kind of co-measure alongside choice sets and design features, as long as they talked about the efficacy of the eventual PTDA. Now, the second major portion of this study methodology was the decision aid development. And this was a mock-up that we created of Medicare and prescription drug plans. And here we This mock-up had information on, what was important to patients, various decision aid flow diagrams, some vignettes to guide patients, and several rudimentary cost estimator examples. And it serves as an addition to the online Medicare Plan Finder website that some of you may be familiar with. The Medicare Plan Finder website is an official online tool provided by the US government, and it helps beneficiaries find and compare Medicare health and drug plans. It allows users to enter their personal information and preferences to view a list of available plans in their area. They can insert what medications they're taking to get more precise cost estimators. They can get coverage options and participating providers and network information. However, some literature has been focused on helping improve the website. Not many patients are aware of it, and this is where PTDAs can come in, and that was the focus of the development of our mockup. Now, going forward to figure one, I kind of talked about this a little bit before, but it was a three-phase flow diagram. We excluded studies that were obviously duplicates, wrong study design, where things weren't the main focus or wasn't insurance related, or if there were wrong patient populations or interventions tested. And this was really as like a research measure because we wanted to focus on RCTs for this to be a systematic literature review. Now, before we talk about all of the results, we have table 1 here, which summarized the 12 main RCTs. Most of these RCTs were from the 2010s. And here we have arrayed some of the aims of each major RCT and some of the interventions, which are summarized in the results section. Some of the earlier RCTs really focused on Medicare itself when it was first implemented. And then as you go on, you kind of see the PTDAs discussed in the RCTs increase in complexity or depth of information provided, as there is a lot of online information and guides that already exist. So these are really either supplemental or providing information that other pieces don't exactly provide to help the aims of the PTDA. Now, looking at results, there were 12 relevant RCTs found discussing efficacy. Now, secondaries measures such as numeracy, literacy, and financial effects of the PTDA were noted. And in an expanded diagram, and I'm more than willing to talk about this if you contact me, there were a lot of other secondary measures noted, but efficacy was our main measure. Now, 5 studies updated the existing online or print tools with PTDAs, and there obviously that means there's 7 studies that found similar results with novel PTDA tools that were created for the focus of their study. Now, these 5 tools, critically, some of them were editing the Medicare Plan Finder, either adding things on or supplementing it, and all of these things were found to be effective. 4 studies measured the success of design changes of the PTDA. So this is choice set, which means changing the amount of plans that are posted on the decision aid, and they were found to be efficacious. 7 out of 8 studies showed that use of PTDAs increased knowledge and literacy, and 5 out of 6 studies showed that PTDAs increased the satisfaction of end users. Now, 4 out of 5 studies examining the financial effects, so this is in effect the financial toxicity effect and seeing if it helps patients with selecting lower cost plans, found that PTDAs associated with patients, they selected lower cost or higher quality plans, which all of these results summarized show really promising research efforts and are the focus of our discussion and future implications section. So yeah, to go on to discussion, obviously most of these studies showed that PTDAs generally demonstrated efficacy. Here we can see like they increase the satisfaction of patients, they increase their knowledge and literacy of the insurance system and selection process, and help patients select higher value or lower cost plans. Some studies, to be noted, showed non-significant results due to enrollment periods, like when the study was going on, and the structures of their participants, how much literacy they had going into the program and what materials are available, or if they're of a certain disease type. There were some follow-up studies done. I think here in the RCT summary section, you can see the ICANN PIC trial. That one had supplemental trials that also showed PTDA efficacy, whereas initially it showed non-significant results. So that is to be noted. Many studies also elucidated patient design preferences in making PTDAs more useful and efficacious. So generally, you'd want to decrease the total number of choice sets and the total complexity of your PTDA as a general rule. And you want to increase the personalization of your tool. So you want to have it tailored to the individual, so they will have to insert information about themselves, and that way it's more useful to them. Some studies included intermediary cost figures, so costs such as copays. These actually increase the complexity of the PTDA. Users just want the end-based costs, like you want to have the cost-based information sorting, and that makes the PTDAs more useful. So generally, you want to have your information low, personalization high, have your costs easily visible, and you want to have those with fewer options to help those from lower education backgrounds. And we also found that PTDA designs that were tailored to patients from high education backgrounds are it's okay to have a little bit greater options, a little bit more complexity. But again, this goes back to the personalization piece. You want to tailor it to your target population. Now, PTDAs were found to be widely used in Medicare, Medicare Advantage, and PDP use cases, but they can also be used in more niche patient populations as shown. And the ICANN PIC trial by Polity et al. Was used for cancer patients. And Dr. Anna Hung, who was my mentor for this project, is attempting over a 3 to 4 year period to develop PTDAs for the veteran population in the VA. Also, interestingly, PTDAs are tailored to like an older age group, those who are qualified for Medicare, but no preference was shown within these trials for online or print media. But we theorized that, it might be easier for patients to understand print media, but as long as online you have included not too much information and it's easy to use for the end user, then no preference will be shown. Now, this leads straight into future research implications. The trend towards PTDA customization and personalization has increased in the past couple of years because of increased additions such as the Affordable Care Act, such as Medicare expansion, such as Medicare Advantage. And patients have to be included as a part of a user-centered iterative design process. And this is what we attempted to do with the second half of the study, where we created the mock-up. We had the 2 patient panels and we included their feedback. Now, other patient groups, such as those with more chronic diseases, Polity et al. Looked at cancer patients, but other diseases can also be looked at. We can look at the VA or dual eligible patients critically can also be and should also be engaged with more tailored information and aids to supplement existing materials or to be standalone. Now, this systematic literature review was the first of its kind in patient insurance decision aids. There's been plenty of work done on patient decision aids overall, but because there hasn't been too many studies over the last 2 decades, one of the biggest research implications is more research on the impact of PTDAs should be done. So we can conclusively figure out what features do and what features don't lead to direct efficacy, and we can create more scalability in these studies. Effects on financial toxicity should also be further assessed and scaled up. Overall, I believe that PTDAs can be an essential part of patients choosing or switching insurance plans. And I hope that the mock-up that we create with this summer study can help inform the development of PTDAs for not only the VA, but for other broader population groups. Thank you.